Hello and welcome to Lesson 4 of Thrive Through Menopause. This is Wendy Demerick, and in this lesson we're going to be looking at some common conditions that come up for women in menopause. And really it's actually a much bigger topic than I was thinking. So I've actually ended up changing how I was going to do it because I thought I'd better give you a little bit of research finding and a bit more background and so on. So this is really a journey lesson that's sort of information based, and then after this, lesson 5, we'll be starting to look at some solutions and different therapies and what to do. So this lesson is just to alert you to some things that are involved in conditions and signs and symptoms that come up in menopause. So let's get stuck into it. Thank you for joining us. So this is a Natural Woman Network program, and you can get Radiant Women book and my other products at the radiantwomenbook.com site, which I'll just show you here. And it's on lots of places in this program. So just if you read through the disclaimer again, and just making sure that you keep yourself safe and realise that this is information that's general purpose. It's not designed for any particular one person, and that if you have any concerns that you see your practitioner, or I do some online consultations as well, quite a bit actually. So there's a lady who looks quite angry. I don't know about you ladies, but over the years, as a practitioner and as a woman in community, I've heard some really appalling things said to women about their menopausal journey. A lot of them that really discount that it's happening, and some of the research that's done tends to back this up a little bit until you look a little bit more deeply in it. So Mad Mary here, she's feeling pretty mad, and this is an example of some of the things that are said to me, and this was said to me quite a while ago by a practitioner who actually knows what I do, and a lot of conventional medicine practitioners have referred a lot of women to me over the years, so there's lots of great, more holistically minded practitioners, but you know, there's still a lot of people who are just really not aware of some things. And after he said it, I just thought, wow, this is really interesting. And if this happens to me, and I'm pretty aware and able to say my piece, what happens to other women? And I get to hear what happens to other women. But this person said to me, you know, I don't really think this whole menopause thing is about hormones at all, really. It's more because women are just going through lots of emotional issues and social issues and so on. Now, those weren't the exact words, but that was the flavour of it. To be honest, I was so lost for words. I was absolutely stunned. And then I actually stopped myself saying, well, you know, if that's the case, why are you prescribing HRT if it's not hormonally based? And I wondered if perhaps they're still doing that there. So I don't know what experiences that you've heard about, but there is a lot that discounts women's experience, and quite a lot of women have come to me over the years and said, you know, they've been made to feel it's all in their mind or that it's all emotional or whatever. But I can tell you there are definitely hormonal issues involved in the perimenopausal journey, particularly that closer to the climacteric. And there's a lot of evidence to back that up. But it's all still a bit of a mystery, the whole hormonal thing. I don't know why I work with women and hormones. It is complicated, but it's always challenging and rewarding. There is quite a bit of stereotypical thinking when it comes to menopause. And I'm not alone in my experiences of having been discounted in my own menopausal experiences by practitioners. This is a quote from Deborah Seychelles' book, who's a medical doctor, and she has a lovely book called Women's Moods, What Every Woman Should Know About Hormones, the Brain and Emotional Health, with Jay Watson. And she gives a bit of a story about how she was at a fairly young age when she started having some hot flashes, or hot flushes, which depends which country you live in. But it's actually quite common for me to see women in their early 40s who are having hot flashes, even as lately as yesterday in my clinic. So she mentioned her hot flashes to her colleague, her medical colleague, who looked at her and basically laughed at her or scoffed and said, "This can't be happening because I was far too young." Stereotypical thinking, once again. And she was very aware that her experience was being discounted and wondered how many other women are invalidated by their practitioners in this way. So I bring this up because over many years, I've had women in tears in my clinic saying, "I'm told I just have to put up with this, that it's, it'll pass, it's all in my head, don't worry about it, and just, go and have a holiday or go home and have a nice drink of wine," or something like that. And I'm hoping that these days that isn't as much of an experience for women as it has been in the past, but it certainly was a feature in the past. And as a result, lots of women suffer. They really, really suffer. And I have been ticked off for women before when they first see me, and they're quite annoyed, not necessarily at me, but they say, "Why weren't we told about you?" Well, I'll leave that question and the answer of that to you. There are reasons for that, but one of them is we don't have big budget for advertising, and mostly it's word of mouth. So when you've got hormonal imbalance or, disharmony within your system, there can be lots and lots of things that contribute to that. I've listed some. It's by no means a definitive guide, but some of the things that I've found over the years that can really contribute to disharmony at this time of your life. Well, the big one is stress. And I have mentioned that in other lesson journeys. The stress factor, I haven't met one person yet whose situation isn't exacerbated by stress. It's just that you might not realise that. And that can manifest in lots of different ways, like back pain, depression, anxiety, irritable bowel, all sorts of things that you might not realise are stress because you might be looking at them in isolation. So just always keep in mind the stress level is really important. And as I said earlier on in this course, sugars and starches and sedentary lifestyles contribute a lot too. The dietary things are really, really important. If you were to do nothing more than look at some dietary changes that support your metabolism, as, for example, I've put with the anti-inflammatory diet, and look at your stress levels and put in place changes to manage that, you'll be going a long way towards, finding that you're living more in harmony with yourself. But there can also be deficiencies in certain nutrients. A big one I've found is magnesium, and we'll go into that in the next lesson 5 when we look at some remedies. GIT, basically shorthand for gastrointestinal tract challenges, and I've mentioned before that if you have gut dysbiosis or your gut microbiome isn't ideal, then it can really affect your hormone balance quite a lot and your energy and all sorts of other things. Inflammation, here we go, anywhere in your body, can be a result of the previous 2 points and other reasons as well. So that tends to up the ante a bit. Thyroid disorders are pretty renowned for causing some sorts of hormonal havoc in your other hormones, not just your thyroid hormones. And it's really important that if you're getting your thyroid tested, that you also do your body temperature, as I've explained earlier on how to do that. Because you can actually have what's considered fairly in range or normal thyroid test, but if you've still got symptoms and temperature control problems, you may well have a thyroid problem that's not showing up in testing just yet. And it's important to do several of the thyroid tests, not just one. It's quite common for the TSH to be done. So when you speak to your doctor about that, just see if you can get a panel of thyroid tests. It's up to your prescribing practitioner to sort that out, but just a few little tips. If your hormone detoxification pathways in your gut and your liver aren't working well, you're going to have a bit more of a hormonal imbalance as well. So we'll go into some possible solutions for that in the next lesson. Xenoestrogens, that's like synthetic chemicals, for example, some plastics and some toxins that are used in the farming industry and all sorts of industries can be what's called hormone interrupters. So it's very important to live as toxin-free as possible. And this is particularly important with your foods, but also with your household and your body care products. And that's why I have the My Essence products myself, because they're totally organic and certified organic and so on, and they're very good. They work really well. I will actually put the My Essence link on this slide 6 information on the references and links charts. Insulin resistance, which I'll bring up a bit later in this slide, that's to do with your blood sugar ability of your body to take it up and all sorts of other things. And especially if we're putting on weight around our tummy, we tend to be more prone to insulin resistance. Genetic predisposition. You know, I noticed many years ago, before there was even much in the way of research on this, that a lot of women I was seeing were very susceptible to even minute changes in their own hormone levels, let alone if you throw in synthetic hormones. So, and that's particularly the case, and there has been research to back this up, that if you've tended to have premenstrual dysphoric disorder, PMDD, or severe PMS, which is what that is, and you might have had postnatal depression, you might have a predisposition to have more signs and symptoms at the acute perimenopausal stage. So just be aware that that's something to take into account. A lot of people ask me, you know, should we get laboratory testing to see if you're in menopause? Well, sometimes this can be very useful, and it's always good to have preventative testing as well. So if you're going to your practitioner, you can get whatever test they think is necessary. But it has been found that some of the tests to determine if estrogen levels and so on might not be as effective, because it's been found that women's breast estrogen levels might be 50 to 100 times higher than that actually found circulating in the blood and the blood test results. This is from the Journal of Steroid Biochemistry and Molecular Biology. So all of these references and links are on the references page you can download. Other people say, should I do blood or saliva? I tend to mostly use saliva, but that's not always effective either, because, say, for example, if you're on hormone replacement therapy or steroids or anything like that, that can affect the results as well. So it is useful to do some testing, but I've always found that the most useful thing to do is to do a really good case history and look at the observations of signs and symptoms and current conditions, and use testing definitely as a supportive benchmarking. And it's really quite useful at this time of life to have your 2,16 estrogens, hydroxyestrogen levels tested. This gives you a bit of an idea of whether you have an overabundance of the 16 proliferative estrogens as opposed to the 2 less proliferative and weaker estrogens, and how that might be contributing to your signs and symptoms and experience as well. So your practitioner will be able, if they understand about these tests, will be able to do that. I often do that with women pre-menstrually. If they've got a lot of menstrual problems or if there's premenopause or perimenopausal problems. And it can be a bit of a protective thing to do that as well. And a lot of people can be very confused because they'll have signs of lower estrogen, like hot flushes and night sweats and sleep problems and so on. But they'll at the same time, they'll have signs of PMS and breast tenderness, fatigue, bloating, low mood, and they're possible signs of estrogen excess. So it can be very confusing. And when people come to me and say, you know, I just want something to make all this better, I do have to spend a fair bit of time explaining that it's a bit of a moving feast and that something that we're using to assist now in a while might not be very useful because things are changing all the time. That's why it's called the change. It's one reason why it's called the change. Another reason can be you might feel like changing everything in your life. So just be aware that it's not just all about hot flushes and sweats. Actually, some of the most common signs and symptoms I see are to do with mood. So, and some people say, I'd rather have the hot flushes than have the mood problems. There have been quite a bit of studies done over the years about whether or not it's considered that the menopausal transition contributes to mood disorders, such as depression and anxiety. And a lot of them have found that there is a link. And there can be such drastic fluctuations in the estrogen levels over that time that you can sometimes think you might be going a bit crazy. And it's a comment that many women make to me. I call it from Mother Teresa to Hagar the Horrible in 5 seconds flat. It's not somewhere I haven't been either. So just be aware that that does happen, and there is quite a bit of evidence of that happening. It's not all in your mind. Previously, you know, this current psychiatric review findings was 2012, but previous to this, there seemed to be a lot of efforts going into proving that there wasn't any link between depression, anxiety, and the perimenopause. But I think if you ask a lot of women, they will find that they might have suffered with this for the first time in their life, or that they might have suffered previously, but it's been exacerbated at this time in their life. So that's something to be aware of, and that's why it's so important to do your signs and symptoms journal so that you know what's happening. Anxiety, well, the moods, this is the Menopause Journal, 2013, okay, and it's reporting on the incidence of anxiety at this time of life. And yes, I see it all the time. Moods can seesaw between anxiety, depression, agitation, tension, anger, and then you can be just feeling like Mother Teresa again, all in one day. It can be really exhausting. And it can lead to a lot of loss of confidence for women too, because, and I've experienced this myself, I thank heavens for my herbs and nutrients and dietary changes and my friends and everything, because you can lose so much confidence. And I've met many women who have just stayed at home a lot because they weren't sure how they were going to feel on the day. And that's a very valid response in a lot of ways, because no one wants to feel embarrassed or cranky with, you know, when they're out all the time. You want to go out for a good time usually. But we just need to be kind to ourselves at these times. So with this review, it was found that women with high anxiety premenopausally may be chronically anxious, but they might not have had an increased risk of high anxiety. However, people with low anxiety before the menopause transition were found to be more susceptible to high anxiety during and after the transition. I might bring that to task a bit, because I think that a lot of people can be mildly anxious, but it can really rev up at this time and you can do your head in. Here's another quote from, just waiting for that to go away. a couple of studies. So this was another literature review. I tend to do a lot of reviews of the research. So this was the first one was a Harvard study of moods, and the second one was a Seattle midlife women's health study. And the references for both are on the reference page for slide 12. And the first one, the Harvard study of moods, found that women with no history of depression were nearly twice as likely to experience depression in the menopause transition compared with premenopausal women. So that's pretty conclusive, and that's a pretty big number. The other study, the Seattle one, showed that depressive symptoms, they tended to increase late in the menopause transition, what I would call the perimenopause to climacteric stage, that maybe year or two just near the end of your last period. And that menopause stage increased the depression scores more than age. So age wasn't a factor in this. It was what stage of the menopause transition you were at that seemed to be more important. So don't think it's all about whether you're 45 or 55. It's more, and I've found this myself with people, you know, at the premenopause stage, you can tend to go in and out of things. You can be right for months and then might have a hiccup. But the perimenopause around to the climacteric, you know, things can change a lot more quickly. And that's not going to be for everyone, but certainly for a lot of the people I see. I'm also acknowledging that I tend, of course, because I'm a practitioner, I tend to see women who are having problems. I've certainly met lots of women in the wider community who've had much milder concerns or none at all. So it's different for every woman. So what's blood sugar got to do with hot flushes? You might wonder that. It's I think some years ago I might have wondered that too, but there does seem to be a link between glucose and insulin resistance and hot flashes, or hot flushes and night sweats. And it's pretty important to keep your sugars down. This is why I'm so big about the sugars, because insulin resistance isn't just about things like polycystic ovarian syndrome. There's lots of other health risks when you're insulin resistant. And that is, you know, leaning towards diabetes, or what's called pre-diabetes, and lots of syndromes and so on, such as cardiovascular disease, arthritis. There's been a link between this and brain health. So if not for any other reasons, it can be very helpful with your hot flushes and night sweats to look at just getting rid of the sugars and a lot of the starches from your diet. Some people alone, that's helped a lot. Other people, it will take more. So it's going to be different for everyone. I want you to play around a bit. And on that note, so many women say, and I've experienced this too, you know, you go into a room and you think, why did I come in here? I'm losing my mind. You go back out to where you were because you think, if I go back out there, I'll remember it. You do, and you come back in again and you forget it. No, that's not dementia at this stage. I call it the menopause brain. But some people are like that anyway, because we get really focused on a task and, you know, forget what we come there for sometimes. But it's really important to realise that a lot of the changes that you make to experience a bit more of a cruisy time in the menopause are going to enhance your brain health as well and take away some of the risk factors for developing neurological problems. And you can never promise that because there's lots of other things involved, but it's worthwhile reducing your risk as much as you can. This literature review from Frontiers in Science concludes that reveals that the onset of menopause in midlife can elevate the vulnerability of women to Alzheimer's disease, and that an increased risk is likely associated with depletions of estrogen. I'm not so sure about that because just about every woman I've helped through it have managed to get really fine brain function back. So, but, you know, there have been studies that are pointing to that, but I think there's lots of other things you can do to reduce your risk of that. Central adiposity, that means increase of weight in your torso, and inflammation are major drivers in neurological health as well. So obesity is a precursor for lots of conditions, and lots of women do find that they can tend to put a bit of weight on around their tummy at this time. We'll talk about that a bit more later. So not to panic about this, because some people's idea of putting a bit of weight on is a bit different to others. Okay. So I've got to put up an article on my LinkedIn page, and you'll see the reference and the link to that in the references section for slide 16, because so many people are really concerned about this, because we are living longer. I mean, 100 years ago, a lot of people weren't living, a lot of women might not have been living long enough to go through the menopause. The average age was about 55 at death. So now we're expected to live into our 80s, so we might have a third of our life beyond menopause. So what we have to make sure is we do everything we can to look after our brain as well as the rest of our body. So if you have a look at that article, it just gives a few tips, natural and complementary tips on how to start to put in place some things that help look after your brain a bit better. And of course, those tips tend to have an effect on your whole body health. So that'll affect your hormone balance as well. Now, lots of women, I actually have for many years done a strong bones program, because many women tend to find that they have been diagnosed with osteoporosis or osteopenia beyond menopause and well before then. It's not a bad idea to get a bone density test in your perimenopausal time, if you possibly can, before a few years before, you know, I would say from at least 45 onwards. Just depends what's happening with your hormones. Some people might not stop their menstruating till their late 50s. And it's good to get that as a benchmark testing, so that you've got something to compare it with later, because a lot of women will have a bit of a drop in their bone density as part of the transition, and then it might stop there of its own accord. But I've had quite a few women that I've assisted to build a good percentage of bone mass at various times in their life, and you've got to look at it very holistically, because it's not just about calcium. There's lots of other factors, such as I need to usually look in to see if there's any heavy metals like cadmium, and that's one of them, you know, that can take up space in the bone as well. So there's lots of things involved in your bone density, and there's lots of conditions that can affect your bone density, and I've listed them here, such as diabetes and chronic obstructive pulmonary disease, thyroid problems, neurological disorders, that's brain disorders. There's lots of other causes that I haven't listed here, but the different types of rheumatoid arthritis and malabsorption syndromes, that means you might be eating good food, but you might not be absorbing it well. So, and a lot of that's to do with how your gut functions. For example, gluten is something that can interfere with absorption of iron and other nutrients and cause a malabsorption syndrome. It's not uncommon for people who've had long-term celiac disease to have low bone density. Sex hormone deficiency, kidney liver disease, hyperparathyroidism, because the parathyroid helps control calcium availability. Lots of other things. So if you've had a diagnosis of one of those two things, have a think about if any of these situations are occurring, and realise that there is quite a bit that you can do with your natural therapist about this, and it will take time. One of the frustrating things about bone is it takes a good 6 months to start getting, a little bit of improvement happening. Really, really common to see women who have either started to have migraines and bad headaches for the first time at this time of life, or they've been having menstrual migraines and they've become much worse and much more frequent in the perimenopausal times as the hormones change a lot. And other people I've found just have a lot less than they used to. So it's a bit of a mixed bag. But it is really a blight on your day to have a migraine. And it can manifest in lots of different ways. It's not necessarily always a particular type of headache. One woman describes to me she gets a funny feeling in her head, and it's like the top of her head, around the fontanella where when you have a baby you see the pulse at the top of the head. She feels there like the top of her head's going to lift off, and that's her only signs and symptoms. Other women might have really full-on auras and sparkly things in their eyes. They might have nausea, exhaustion, terrible aches in various parts of the head and the eyes. So it can present in lots of different ways, and it might even present differently to what it has if you've had migraines or headaches before. Obviously, if it's ongoing, get it seen to by your doctor. You can't, like I've said before, you can't assume everything that's happening at the menopause is just to do with the transition. Always put safety first. So what are some of the common causes that I see when it comes to migraines and headaches? If it's been ongoing, like I say, I ask people to get it checked out medically as well. And, I've been fortunate to have lots of medical practitioners that we associate and work well together, so that's never a problem. Spinal alignment is really, really important. Myself, if my lower back's out, which it can happen because I've got damage there from equestrian events, then I tend to get a throbbing, almost like a migraine, but a sick headache in my frontal lobe, just above my forehead. And I know that I need to go and see my colleague Evo and have an adjustment. Now, in the next lesson, lesson 5, you're going to see a little video where Evo and I have a bit of a chat about some of the conditions that he's noticed with women midlife and what he would suggest. So if you haven't got someone who's really good at helping you with spinal alignments and so on, such as a chiro or an osteopath, I also do bone therapy and other sorts of body therapies that help that a lot too. So it's wise to have a little look around. Muscle tension, for the same reasons, muscle tension is a big contributor to headaches and migraine. So is stress. Stress keeps popping up everywhere, doesn't it? Funny about that. Food intolerances, allergies, they're quite common. I know if I have gluten, within about 20 minutes, I'll want to fall asleep with my head on the table and I'll develop what I call an eye migraine. It's like all the bones around my eyes are inflamed. And that'll last at least 24 hours till it starts moving out of my system. The rapidly changing hormone levels do tend to, you can be fine 1 minute and then I've had this happen to me, walking along going to a seminar that I was actually presenting at. I was feeling fantastic. And then about 2 minutes before I walked through the door, I suddenly got this crashing migraine. Now, I'd never had migraines before. This was some years ago when I first noticed the premenopausal shifts. And I just thought, I thought I was dying. But, it can happen that quickly. And I had to I actually asked for a chiropractor because it was a practitioner seminar to just come and do some adjustments for me so that I could actually go on and deliver my presentation. So that helped temporarily. So nutrient deficiencies, another one, magnesium is quite common, and so is calcium. And toxins, environmental and internal toxins as well, can be a bit of a problem. So once again, living as toxin-free as possible. Is there a higher risk in midlife for migraines? There's been quite a bit of studies done on this as well. This one's from the University of Cincinnati, and you can see slide 20 references for this link. So the risk for high-frequency headache, or in other words, you might say migraine, or more than 10 days with a headache per month, increased by a whopping 60% in middle-aged women with migraine during menopause. Now, that is huge. Just let anyone tell me that's all in your thinking, all in your imagination. So that can, when it's compared to normally cycling women, and that was a big study, 3,664 women were studied for this. So that's pretty conclusive. And yes, there are generally things you can do with natural and complementary therapies to help that. With your skin, that's another thing that a lot of people are concerned about. Yep, it can be a bit of a dry argument for women. You might feel like you're drinking gallons of water and you're still dry. The vaginal mucus secretions can become drier and more scanty. And the eyes can become drier. And you have to be careful with that too, because there are some autoimmune conditions where the eyes become very dry. And to make it even worse, you might have dry skin and you're getting zits for the first time in your life or in years. It's so insulting. So, the skin stuff is pretty important to address, because there is quite a bit you can do to help with the skin stuff, both topically and internally. And I find the skin stuff is often an inside job, meaning it's, what you're eating and how you're digesting it as well. A lot of women have presented to me because they've wanted to look at other options when they've got uterine fibroids. And they have been sent sometimes by a GP or a specialist or another practitioner in natural medicine who doesn't do much women's health stuff. So often with uterine fibroids, you'll have what's called dysfunctional uterine bleeding, and it might be excessive menorrhagia, excessive bleeding. And you can develop low iron levels as a result of that. So the first thing about having fibroids is that generally, if you can get through this, they will shrink when they stop being fed by estrogen after you've had the menopause. But it's important, safety-wise. So I like to know, if I'm assisting someone with fibroids, that they've had it checked out, there's no problems with it, and there's no threat to health and safety. And then we look at some ways of managing it. And sometimes I've actually found that sometimes the fibroids shrink. But there's other things you need to look at, whether your thyroid's working okay, because an underfunctioning thyroid, that's hypothyroidism, can contribute quite a bit to low iron levels and to fibroids and so on. So this woman, Gail, was one of my patients. That's her nom de plume, Gail. And like many of the women I see, she didn't really want to part with her uterus unless she really had to. And she particularly didn't want to have a hysterectomy and go and have surgery, because there were other reasons for that. And one of that was she was just very busy. So she did come to me with the full knowledge of her medical practitioners. And we did manage to get a good outcome with her, in that we managed to control her symptoms long enough for her to get through the menopausal transition with safety. Fatigue is a big one. Just about every woman I see in my clinic at this time of life experiences some level of fatigue. And often it's quite subtle, in that they just say, I just feel like, I just don't have my get up and go like I used to. And some women, it's just absolute crashing fatigue. and they describe it like as if someone sucked all the energy out. I sort of tend to say, you know, the big dude up in the sky's got a vacuum cleaner and sucked it all out. And they can barely put one foot in front of the other. And it's not relieved by rest. It's that sort of fatigue. If you're fatigued and you rest and you feel better, it's not the same degree of concern. And then, you know, spontaneously it can just improve without you even taking any action. That's the sort of thing I often see midlife. And it can be really confusing because when it hits you, it really hits you. You know, it's like a truck's hit you. So it's really important to look at some of the things that can affect that. I'll just go back to that one again. Iron levels, are you taking on too much and it's affecting your hormone balance? Nutrient deficiencies, stress, all sorts of things can contribute to that. So if it's an ongoing problem with the fatigue, it's good to get some help with that if you feel it's really affecting you. So what have the adrenal glands got to do with hot flushes? Well, quite a lot actually, and that's something that people in natural medicine have known for quite a while, because it's really interesting. We can actually do something about that. So the DHEA, which is a hormone excreted by the adrenal glands, I won't go into all the long names and everything, it tends to, this is the Climatric Journal in 2013, it tends to decrease in amounts with age. Now DHEA is sort of a longevity hormone that's secreted by the adrenal glands. So there's a natural occurrence of that decreasing with age. And it can be very different concentrations between different women at the menopausal time. And I do test for that with salivary hormones. I test for that and cortisol levels, melatonin levels, and a few other tests as well. And the consequence of that is that because they've decreased, that a huge proportion of women, and they say 75% of postmenopausal women, so that's having been through the change, have been found to have low levels of DHEA. And so they suffer from signs and symptoms of hormone deficiency. So, you know, when you stop excreting so much estrogen from your ovarian, from your other endocrine glands, your adrenals tend to take it up with a complicated mix of other hormones. So once again, the stress factor is very big in this. And with natural medicine, we have herbs and nutrients and so on that support the stress reactions. They're called adaptogens, so they can help with that quite a bit. So hot flushes are considered these days to be a derangement in the temperature regulation in the hypothalamic temperature regulating centres. So what's been found is that women who tend to get more hot flushes and night sweats tend to be more sensitive to the changes in temperature than ones who don't. So they tend to have a lower range, meaning that the normal is more narrow, so they can go off centre quite easily. And decreasing estradiol, which is a form of estrogen in the serum and the brain areas of importance for temperature control, can alter neurotransmitter activity as well. So, you know, the nervous system's involved in this. So once again, stress can affect hot flushes and night sweats. And most people I see say, oh, you know, I've just had this thing happen and I noticed I started having hot flushes more again, and so on. So we actually need to support the adrenal glands and nervous system more than anything when this happens. Aches and pains. Have you found that you do tend to be a little less fluid in your movements and you might feel more aches and pains lately? And that's really common, I see, for lots of women. So a lot of women tend to put in place, maybe sometimes for their first time in their life, you know, things like yoga and Pilates and stretching and so on. And that's a really good thing to do if you don't have any injuries. And they notice that there's more aches and pains in various areas which they might not have had before. So it can get quite puzzling at times. A lot of women have noticed exacerbating of old trauma sites, like, they might have had a back injury or something like that. And these changes in hormones can unsettle things, so can stress and, all the other things that impact on that, like sedentary lifestyles, dietary, and development of new challenges in your body. So just be aware that if you're feeling more aches and pains and you're not sure why, it could actually be to do with the perimenopause. How do you know? Well, I like to, once again, get people to keep signs and symptoms charts as well as the temperature charting, because low thyroid can actually make you feel much more sluggish and more aches and pains as well. And it's good to do it for at least 2 months. If you need to get an opinion at that time, medically, that's good too, but just keep doing your charting so that you start to notice if there's certain times that it might flare up. Some women notice that they get a flare up of their aches and pains just before a storm. So there's other things involved in that. So get your thyroid function checked, get your inflammatory markers checked. So there's a blood test called highly sensitive CRP. CRP is C-reactive protein. And any other testing that your practitioner feels is useful. The good old battle of the bulge. It's not just about putting on weight. Some women, especially women who are suffering high anxiety and so on, can tend to lose quite a bit of weight. But a lot of women notice that they might be eating the same, and they might be living much the same, but they're just gradually increasing, especially in their torso. And there has been tests about, there have been research done about this too. And there were conclusions with that, and that was once again from the Climacteric Journal. Women who are older at baseline, so when they started, gained less weight than the younger members. So their skin fold measurements and waist measurements and waist-hip ratio all increased during the menopausal transition. So that does tend to point towards age actually being a factor with weight and the time of your menopausal transition. It's interesting that they found that women who are having hormonal therapy didn't gain this weight. So obviously hormones are involved in this. And what I often find is sometimes women come to me just because of the weight, but I don't treat weight problems as something on its own, because there's always other things involved. But what can happen is, we can start to go on these really extreme exercise and dietary things and end up here. You might have an injury, or you might just overdo it in your enthusiasm. So just don't end up there. Take it slowly, and if you need to, get some help with that. And it's not just in your mind. There really is a correlation between the perimenopausal hormone changes and weight changes. Another paper in the Climacteric in 2012 reports that hormone changes across the perimenopause greatly contribute to increased abdominal obesity. And that can lead to physical and psychological morbidity, meaning, steps towards your demise. So, and they say that there's evidence that estrogen therapy can prevent this. So once again, clearly hormone related. And I don't find, there's lots of things you can do about this. If you're into estrogen therapy, well, that's fine. That's not my medicine, so I don't prescribe that, but that's for someone else to do. But there is certainly a lot you can do weight-wise, and we'll go into that in the next section. So that's the end of Journey Lesson 5, and like I say, we'll have the interview with my chiropractic Evo in the next one. That'll be in the download section, and we'll be looking at some simple remedies therapeutic aids and different healing modalities in the next one. I look forward to seeing you then. And just make sure that you have a look back at your signs and symptoms chart, because you've been doing them for a few weeks now, and start to notice if there's any emerging trends with your signs and symptoms, and go through the journal book, and fill out those questions and get yourself ready for the next lesson. Thank you very much. Bye.